I want to start off by thanking everyone for attending today and for your interest in understanding the newest addition to the appendices of the CPT code set, which is CPT Appendix S, AI Taxonomy for Medical Services and Procedures. The AI taxonomy was created to offer guidance to stakeholders in the CPT process, such as yourselves, to better understand how AI medical services fit into the CPT code set and how the types of AI tools or applications that you are currently using to perform services or looking to implement in your practice may already fit into the code set or could in the future. Okay, so starting off with some background on the DIMPAG and the DIMPAG AI work group. Because the DIMPAG AI work group developed the AI taxonomy and submitted it for review to the CPT editorial panel, so in 2016, the AMA surveyed practicing physicians and found that they were eager to incorporate digital medicine into their practices. However, they questioned things like, does it work? Will I get paid? And will insurance cover this for my patient? Is it safe? And will it work in my practice? So with this information in mind, the AMA went about engaging experts in the field of digital medicine to better understand what was needed to address physicians' concerns. And later that year, the AMA established the DIMPAG, which is advisory to the AMA and a voluntary group of clinical subject matter experts with experience integrating digital medicine services and tools into clinical practice. The DIMPAG advisors identify payment and coverage strategies to overcome existing barriers to digital medicine adoption. They are selected based on their individual expertise and experience and not as representatives of their specialty societies, institutions, associations, or companies. The DIMPAG recognized the need for specific expertise in artificial intelligence in healthcare, and that's why the DIMPAG developed a subgroup called the AI Work Group. And this is a standing work group of the DIMPAG focused on digital medicine that specifically utilizes AI technology. There are both DIMPAG members and experts in AI and machine learning included in the group. And the charge of the work group is listed on this slide. On the last point, I did just want to point out that at the AMA, we use the word payment to describe what some people outside of the AMA call reimbursement. So when I say payment, I'm referring to the payment that physicians receive for the medical services and procedures that they perform from both public and private payers. And also on the last bullet, I want to point out that the word considering was selected intentionally to be clear that although both the DIMPAG and the AI work group discuss coverage and payment, issues related to AI, this generally is in the realm of thinking about coding solutions. And so it's intended to expand access for both physicians and other QHPs to provide access to patients for safe and effective AI services. So the groups do not directly advocate to payers for specific coverage policies. The AMA's advocacy department is responsible for that type of advocacy work. And the DIMPAG and DIMPAG AI work group may provide expertise and relevant use cases to aid in the AMA's larger advocacy efforts. The relationship between the DIMPAG and the CPT editorial panel can be confusing at times because there is a high level of interaction and engagement between the two groups. However, it's important to keep in mind that the AMA is not an advisory body to the CPT editorial panel. Rather, it's an advisory body to the AMA. And the DIMPAG and DIMPAG work groups sometimes submit code change applications to the CPT editorial panel when there's an identified need for guidance, like with the AI taxonomy, or if a specific coding gap has been identified. Current procedural terminology, CPT codes, offer doctors and healthcare professionals a uniform language for coding medical services and procedures. The CPT editorial panel is responsible for maintaining the CPT code set, and the panel is authorized by the AMA Board of Trustees to revise, update, or modify CPT codes, descriptors, rules, and guidelines. The panel is composed of 21 members, and the panel maintains an open process and convenes meetings 3 times per year to solicit the direct input of practicing physicians, medical device manufacturers, developers of the latest diagnostic tests, and advisors from medical specialty societies. New and revised Category 1 codes that are approved by the CPT editorial panel are sent to the Resource-Based Relative Value Update Committee, known as the RUC. And the RUC develops recommendations about the valuation of the medical services described by CPT codes and forwards those recommendations to the federal government, specifically the Center for Medicare and Medicaid Services, for consideration as they develop the payment policy for the Medicare physician fee schedule. So each part of the system, coding, coverage, and payment, are essential for broad adoption of innovations by physicians, and coding is an important step on the pathway to payment. In the next few slides, I will discuss the issues we currently have in describing AI innovations for healthcare and the work that the AI work group did to determine what sort of guidance would be most relevant to innovators in this space. The AI work group conducted a heuristics exercise looking at what AI innovations are currently available and what is foreseeable in the near future. At that time, it was out to 2025, which is fast approaching now. And the overall conclusion of the group back then was that there was no precedent for AI-specific descriptors in the CPT code set. So at the time that the AI work group began its work, the only word that had been used in the CPT code set to describe software services was the term automated, due to lack of any precedent for or definition of other terms applicable to AI healthcare services. And you have to remember the CPT code sets are all about words, so it's very important to have those type of precedents and to be able to look to them for future guidance. So the work group determined that the term automated did not really appropriately capture the work done by machines in AI-related services, and that was for 2 main reasons. The term automated connotes a workflow efficiency obtained by utilizing a machine. Moreover, if a task or analysis is conducted automatically, then there hasn't been that clinical judgment applied to the procedure or service for that patient, and therefore the clinical necessity may be unclear. A good example of this is for 3D volumetrics. It may be performed automatically on all chest CT images loaded to a PACS system, whereas the clinical utility of a 3D volumetrics is only established for a subset of the patients undergoing that image acquisition. So limitations in the terminology used in the CPT code set had become an urgent priority due to the rapid pace of innovation and FDA clearance of increasingly sophisticated AI products, which go well beyond what was being described 20 years ago when computer-aided detection products were first described for use in the radiology section of the CPT code set. So as I mentioned in the last slide, there's been tremendous growth in software as a medical device. The FDA recognized the horizon for AI back in 2018 when they issued guidance specific to software as a medical device. And to date, the FDA has reviewed and authorized 692 AI or machine learning enabled medical devices. These are legally marketed and many are considered software as a medical device. And the term is defined by the International Medical Device Regulators Forum as software intended to be used for one or more medical purposes that perform these purposes without being part of a hardware medical device. So in 2020, the DIMPAG did for AI what it had done for digital medicine with the Digital Medicine Services Taxonomy, which is Appendix R in the code set, by launching an effort to develop a taxonomy for AI. And the approach with this effort was to form a subgroup of the DIMPAG that I talked about before, the AI work group, with members that had specific expertise in AI. And they did an in-depth study and came up with, over a series of meetings, came up with the terminology that would become the AI taxonomy. And this was really for stakeholders looking to apply for CPT codes, and really for the CPT editorial panel itself, looking on how to consistently implement AI into the code set. It was submitted for consideration and adoption by the CPT editorial panel at the September 2021 meeting of the CPT editorial panel. So now moving on to a little bit of background about the taxonomy itself. It's for medical services and procedures. And as I said before, the DIMPAG AI work group submitted it to the CPT editorial panel for consideration to actually be part of the book. So although it's not codes in and of itself, it's guidance about creating codes for AI, it is actually part of the code set. So it's an appendix in the back of the book. And it was successful and was adopted by the CPT editorial panel at the September 2021 CPT meeting, and was part of the CPT early releases for that year. So that means that it was posted to the AMA public website and was officially part of the code set effective January 1st, 2022, even though it hadn't actually been published in the book yet. And that was due to the CPT editorial panel really understanding the urgency of this type of guidance and agreeing to move up the release date an entire year. The goals of the AI taxonomy are threefold. First, it is to help both panel members and stakeholders in the CPT process make decisions by establishing foundational definitions relevant to the CPT code set. Second, it is to define the elements of differentiation between AI services. And third, it is to be easily understood by educated healthcare stakeholders who are not AI experts, but understand the CPT code set and reporting professional services. Because CPT codes are focused on the work of the physician or the qualified healthcare professional, in this context, the AI is described by the impact that the technology has on the work of the physician or QHP, both in the amount of work and the changes in the way the service is performed. The AI taxonomy was created to assist CPT stakeholders, including innovators, payers, regulators, medical professionals, patient organizations, in the development of CPT code change applications for novel AI products and services. In addition, it was created to serve as a resource for both CPT stakeholders and CPT editorial panel members to foster a shared understanding of the various levels of AI services and how they can be differentiated within the code set. As we discussed earlier, most innovations have some obstacles to overcome before they reach patients. Among these are questions from physicians, including, does it work? Will insurance cover it for the patient? CPT codes can remove obstacles to care so that physicians can put innovations into practice. So having that CPT codes can sometimes be very important. And the goals of the AI taxonomy are very specific to CPT coding. The AI taxonomy does not address payment directly. However, CPT codes do include the resources needed to perform a service through the practice expense component. So differentiation between the work done by the physician and the work done by the machine on behalf of the physician will help facilitate appropriate valuation and payment of AI. Consistent nomenclature around AI in CPT code descriptors is important because CPT code descriptors anchor the continuum from product labeling to coverage and payment. The taxonomy provided in Appendix S captures current and foreseeable classifications for medical AI applications, and it was designed to take into account product design, features, and functions on the near horizon. The differentiation needed for valuation, coverage, and eventually payment. The impact of technology and the impact that it has on the work of the physician, and the variety of business models and sites of service common in AI that may not be common in other medical services. Also wanted to point out an article that was published in MPJ Digital Medicine, and this was developed by the DIMPAG AI work group and discusses the intellectual background and underpinnings of the AI taxonomy. So now I'll jump in a little bit with the content of the AI taxonomy. So the AI taxonomy provides applicants and panel members terminology to describe AI-enabled innovation in the language of CPT. First, the introductory language of the AI taxonomy states that in healthcare, there's no single product, procedure, nor service for which the term AI is sufficient or necessary to describe its intended clinical use or utility. Therefore, the term AI is not defined in the AI taxonomy, nor elsewhere in the CPT code set, and this may differ from other public or private sectors. More generally, the taxonomy is intended for the work done by algorithms, whether machine learning or not, and encompasses expert systems. So use of the term AI in the CPT context is intended to encompass, is not intended to encompass or nor constrain the full scope of innovations that could be characterized as work done by machines. And it's not intended to convey that the physician is being replaced. In fact, it is quite the opposite. The function of a CPT code is to describe the physician work necessary to perform a medical service. So the terms included in the AI taxonomy were carefully determined based on the experience of the physician using it. This is where we get into the categorization of AI into one of three types: assistive, augmentative, and autonomous. Each of these definitions begins with the foundational feature, which is work being done by machine. For assistive, the keywords are detects and clinically relevant. An assistive service may process data, but this does not include analysis, nor does it generate conclusions. Instead, an assistive service or procedure assists the physician by bringing to their attention something which may or may not be important, but might otherwise be missed. The physician does the remainder of the work, meaning that the physician analyzes the data, determines the clinical meaningfulness of the data, and reports their interpretation of the data. For augmentative, the keywords are analyzes, quantifies, and clinically meaningful. An augmentative service or procedure analyzes data, and just like assistive, this information will require a physician to interpret, draw conclusions, and report recommendations. The physician may perform additional analyses, but interprets the output from the AI device and reports conclusions based on their interpretation of the data. The machine analyzes or quantifies the data according to some clinically meaningful scale consistent with the standard of care. The extent to which the output is clinically meaningful is in the judgment of a prudent physician in optimizing their patient's care pathway. The key features of an autonomous service include cognitive elements of interpretation and generation of clinically meaningful conclusions and recommendations. Depending on the level of autonomy, this may include action beyond the issuance of a report, the work performed by the machine on behalf of the physician is autonomous when the machine automatically interprets data and independently generates clinically meaningful conclusions without concurrent physician involvement. An autonomous medical service includes interrogating and analyzing data. The clinically meaningful conclusion may be a characterization of data, such as likelihood of a specific disease state, which is then used to establish a diagnosis or to implement a therapeutic intervention. And there are 3 levels of autonomous. And for level 1 autonomous AI devices, the device interprets data, draws conclusions, and offers diagnosis or intervention options, which the physician must take initiative to implement. Conclusions made by the level 1 device would require action on the part of the physician to implement, and these conclusions might be contested by the physician. For level 2 autonomous AI, the device interprets data, draws conclusions, and initiates the next step in diagnostic or intervention options. At level 2, action could be taken, but the device would alert the physician. It might be necessary for the physician to endorse or reverse the action of the device. For a level 3 autonomous AI, the device interprets the data, draws conclusion, and initiates diagnostic or intervention options. At this level, action is taken, and it requires initiative on the part of the physician to contest or modify the diagnosis or intervention. As you can see, at every level of autonomy, the physician plays a central role. AI impacts how they perform their work, but they remain critical to the service being provided. The table included in the AI taxonomy is meant as a summation and visual display of the definitions introduced in the AI taxonomy. The table highlights the primary objective of each level: assistive, augmentative, and autonomous. The chart then highlights the increasing level of independence in the machine's amount of augmentation of human work, along with the spectrum of assistive, augmentative, and autonomous. This framework is intended to engender CPT code descriptors, which are discrete and differentiated, and ideally, the resulting coding will do more than simply characterize the work done by the machine, but also clarify the work done by machine in such a way that the coding, coverage, and payment for the services will fairly reflect the contribution of both the physician and the AI. The AI taxonomy is being used by the panel and applicants to the CPT process. I'll go over a few examples of a precedent for each level of AI in the taxonomy. So first we have the CPT code 92229. This was originally created for the 2020 CPT code set to describe an autonomous point of care for diabetic retinal exam. The proposed CPT code descriptor included the word autonomous in the CCA. However, as I was talking about before, the word was revised to automated because at that point, there was no definition of terms applicable to AI healthcare services within the CPT code set. Because of guidance provided in the AI taxonomy, the panel then replaced the word automated with the word autonomous in the CPT code descriptor for this service. 92229 does not require physician interpretation. The work of the machine can independently diagnose diabetic retinopathy. Because an ophthalmologist's interpretation is not needed to make the diagnosis, it can be performed in a primary care physician's office. Category 3 codes 0501T through 0504T were consolidated into one Category 1 code for 2024. And this service is the updated example of augmentative in the Appendix S table. Augmentative is the descriptor here, because the work performed by AI analyzes data to yield clinically meaningful output. However, it doesn't provide diagnosis or management decisions and requires physician or other QHP interpretation and report. The output is clinically meaningful, meaning that although the physician must interpret the output, it is clear how it fits into the patient's care pathway because it is supported by high quality clinical evidence, correlating the output with that from the standard of care. And last, the service, the taxonomy table was updated with this example of assistive, and the work performed by the algorithm detects clinically relevant data. It doesn't provide diagnosis or management decisions. The output of the algorithm requires physician or other QHP interpretation and report. In contrast with the examples for autonomous and augmentative, the output is assistive because it finds data that may be clinically relevant, but is not clinically meaningful, meaning that the data may be helpful to the physician. However, it doesn't transfer any physician work to the machine. The physician must interpret and decide how the information actually influences the patient's care pathway. I wanted to end by pointing out that the AMA has several resources available to help you become familiar with the CPT process and assess what is entailed in applying for a new CPT code if you're interested in doing that. So please check out these resources as you're able, and feel free to reach out with any questions about either the AI taxonomy or the CPT editorial panel process in general. Thank you so much for your attention today. I wanted to hand it over to my colleagues in AMA advocacy to provide their perspective on this topic.
Great, thanks, Sam. And since you've got the, oh, that is the wrong slide. I don't know how that remains in there.
I should have asked you about that, sorry.
Yes, can you click through that?
Yeah.
There we go. Apologies about that. Somehow stuck in our template that I was working off of, and I'm gonna have to have Samantha help me click through my slides since we're working off her screen. But I'm Shannon Curtis, Assistant Director of Federal Affairs, again in the AMA's advocacy office, so based in Washington, D.C. And I'm just here to probably provide a couple quick minutes of color commentary on the payment landscape from a federal affairs perspective. Samantha's obviously our deep expert on the CPT and somewhat of the deeper issues around valuation and payment. But we do monitor in DC just kind of the higher level policies around AI, certainly with respect to the regulatory landscape, and obviously starting to pay a bit more attention to the broader policies around payment reimbursement as well. So, just wanted to provide a kind of couple of notes and perspectives on the federal efforts to really promote commercialization and kind of that wild westy environment we find ourselves in at the moment. But do you mind going to the next slide? So these are just a couple quick notes that I'm sure come as no surprise to anybody here about the current payment landscape for AI-enabled technologies. I'm sure, as you all are aware, we just haven't seen really any concrete movement up at the Centers for Medicare and Medicaid Services towards creation of any type of stable, consistent, predictable pathways towards payment and coverage for these AI-enabled technologies. We've seen a lot of RFIs, so requests for information, where they ask a lot of questions, they want a lot of input, but we haven't seen a lot of subsequent action on those requests for information, at least to date. And I should preface this a little bit by saying that as the AMA, we are slightly more focused on the physician fee schedule side of the payment landscape, less on the hospital rules. So we don't quite delve as deep into the hospital outpatient, inpatient prospective payment system rules, which I know can somewhat differ and occasionally provide some different opportunities and thinking than the physician fee schedule. But we're PFS people at the end of the day, so this will be coming more from that perspective than the perspective of any of the hospital rules. But so CMS really does remain a challenge, although we're obviously seeing a lot of increasing interest and attention being paid in this space. I think everybody is just struggling with not knowing exactly what to do with these technologies at this point in time. That is not helped by the fact that we just don't have any cross-agency, cross-department consistent guidance, terminology, really to work off of it all. There's no real harmonization of evidentiary standards for different aspects of this continuum or spectrum of commercialization. So we really are still in a little bit of a situation where it's a little wild westy out there still. No clarity on the regulatory side or no consistency. Doesn't help the payment picture. It doesn't help the payers in making their determinations at all. But they are not helping anybody by not offering a lot of more clarity or working towards more clarity around predictable pathways to payment and coverage. So, FDA obviously is doing a pretty fantastic job at turning out marketing authorizations for some of these tools, but I know they don't even have the regulatory system right now that they would ultimately like to have. They're still doing a lot of thinking, a lot of work there. So we're expecting even the FDA landscape over time to probably evolve from what we're seeing now as well. So a lot of work to do, a lot of lack of clear guidance, and that just impacts everybody's business and pathway at this point in time. What we've kind of heard a little bit of too that causes some consternation, I think, both for us at the AMA and certainly for the payers, is some companies seeking some pretty high payments for some of these technologies, which I think is going to consistently cause problems for the payers and struggling to know what they want to do with that. Our perspective at the AMA on payment is that AI should add value. It should advance the goals of the quintuple aim. So looking at things like reducing healthcare costs, doing it better, faster, stronger. If it's not doing those things, um, you know, the interest in paying for it is going to be less, and there's certainly not going to be interest in paying for it at levels that might be equal to what they can pay a physician to do it, because that just takes the value proposition away from doing so. So those are kind of just a nutshell of what we're seeing right now. But again, I'm sure none of this is really news to anybody on this call. So Sam, do you mind? I did just want to call attention to, if folks were not aware of, some efforts across the federal government to help address some of these problems, or at least take some steps towards helping to address them. FDA is actually taking a much greater interest in the role that they play, or that they can play, in helping speed products to commercialization and really avoid that idea of the valley of death. So we have seen some developments on the FDA side that are actually very encouraging, and we think might be very, very helpful at the end of the day to companies seeking both FDA approval and ultimately reimbursement from the payers. One relatively new effort at FDA is this Total Product Lifecycle Advisory Program. It really is geared towards applicants at FDA and geared towards engaging those applicants much earlier in the process. So being able to connect them directly with CDRH, but now also being able to connect them with non-FDA stakeholders that touch a whole host of different elements, from, management consulting, like, CPT advisory. We obviously have this payer communication task force I'll talk about in a minute, but this really is a neat effort to help align expectations with applicants, with FDA, and then ultimately pointing towards CMS and reimbursement there. A big thing to note among a host of their goals of this program is aligning expectations with regards to evidence generation. That's both for FDA and their expectations, but hopefully moving into some understanding of what the evidence expectations for the payers will be as well. So you can ultimately help design your clinical trials and stuff from the get-go with an idea towards meeting the expectations for evidence generation of both FDA, CMS, and other payers as well, which relieves burden on everybody at the end of the day, and really gets folks hopefully through this entire continuum much faster, which much less heartburn than you might have otherwise without some of this guidance earlier on in the process. I should note that the TAP program at the AMA, we do have one of our CPT staff that's participating as an advisor. So that's helpful information and should provide some more early education to applicants that might not be as used to dealing in this space and might not have the backgrounds in dealing with both FDA and then with the payers, CPT, the RUC, things like that. So we hope this will be a very valuable program and the applicants take advantage of it to help speed this process along. But as I also mentioned, FDA has also set up this great payer communication task force. They have this early payer feedback program, and they've got a number of payers that have agreed to participate in this program to help really connect again with manufacturers, developers really early on in the process so everybody can be aligned and make things a little bit easier on everybody going through the FDA and CMS process. This also encompasses the parallel review program. That program's been around for a really long time. It encompassed this notion of going through both FDA review and CMS review for payment at the same time. I will say that has been an extremely underutilized program. Federal agencies are not necessarily known for their great interagency communication, which has really challenged that program over kind of the long run here. But there is a very clear renewed effort at the federal level to get better at this interagency communication and really collaborate to make this process much easier than it has been in the past. So we're very hopeful that we will see improvements in these communications, in these feedback programs, and those things going forward. So. And just one more quick note about what we have seen from CMS. Again, I'm sure many of you have heard of this, a new effort at providing at least some type of pathway for payment and coverage for emerging technologies. This originally started as a little bit of a different animal a few years ago with the Medicare coverage of innovative technologies proposal. That was unfortunately scrapped due to some concerns about the type of coverage and the timeline for coverage that it provided. And it eventually morphed into this program, which we're hoping we'll see up and running pretty soon. But the TSET program is an expedited pathway towards Medicare payment and coverage. Only FDA breakthrough devices are eligible for this pathway. So you do have to have that designation and go through that pathway of review at FDA in order to be eligible for this pathway with Medicare payment. So really what it does is it utilizes a coverage with evidence development national coverage determination pathway is really an on-ramp to full national coverage determination or potentially a lack thereof over a period of years. So the idea is that a company can apply for this pathway before they've actually received their FDA market authorization. So they can really get this very, very quick on-ramp with CMS to coverage. So they will be covered under this coverage with evidence development NCD basically immediately upon FDA approval or clearance. CMS is dedicated to working with these companies throughout this program to help them design evidence generation, evidence collection, and engage in evidence review with them. So there's a partnership working through this pathway. So whenever that evidence is ready and CMS is satisfied with it, they can go ahead and do their full review for a full permanent coverage determination. It does have a couple of drawbacks in that in order to receive coverage, you must have a current Medicare benefit category. Not all of the AI-enabled technologies that we're seeing have a Medicare benefit category as of now. Things like the digital therapeutics come to mind. Those currently do not have a benefit category at CMS. There's been some legislative attempts to create a new benefit category for some of these tools, But they run into problems in that they're unfortunately very costly. And the one thing the Medicare program does not have a lot of extra of right now is money to pay for things. So that is a big uphill battle on some of these new ideas about coverage and payment pathways, is they are just limited right now, and a number of these new digital technologies might not fit squarely in a benefit category that's required to avail themselves of these new opportunities. So always a challenge there. With this one also, this is not specific to digital. So this is not just for AI. This is just not just for a CMD technology. Really anything that has an FDA breakthrough designation could potentially qualify under this pathway. So you're competing with a number of other types of devices potentially coming out of FDA. And probably another one of the biggest drawbacks here is that they're only expecting to take about 5 applicants a year for right now, and they're saying that's due to CMS resource constraints. So we're hoping that that situation changes over time. 5 is not a lot, but hopefully at least over time, we'll see this pathway work and be expanded. So it's a good start. It's a good pilot. We'd like to see more, but at least we have something, which is better than nothing. So. And this is just a little diagram overview of that TSET pathway and kind of the continuum that it's thinking of operating along once that notice is finalized and the program can get up and running. And just a quick note, I know we're running out of time here, on just some AMA policies, principles, and perspectives here on AI. As I mentioned before, I think that the position of the AMA is that AI should only be reimbursed when it, again, seeks to meet the goals of that quintuple aim, as those are outlined here. It really only should be reimbursed when it adds value. We don't want to see technology just for technology's sake. I'm sure that many of you know that integrating new technologies for our current physician population is not always the easiest thing, especially for the aging portion of our physician population. If we're adding technology just because it's neat, that can create more burdens for our physician population than it helps relieve. So unless it truly, truly adds this value, again, is better, faster, stronger, is improving outcomes, it's, improving health equity objectives, we don't necessarily see that there's a need for those to be reimbursed. But the ones that do, we should absolutely be supporting new efforts towards payment and coverage. That does not mean, however, that the AMA necessarily has taken a definitive position on exactly what those pathways to coverage and payment should look like. But we do know that we need to be working towards them, and we will support efforts to be working towards them as we continue to have those opportunities. And this is just kind of one last slide, not specific to payment coverage or anything like that. But if this slide deck is going to be shared, there's some links in here to just our resources on AI that we have created. A lot of these are geared more towards regulation of AI, but we obviously probably all know that the regulation of AI and then moving towards payment and coverage are very, very important to each other and are obviously interrelated as we're going forward. So again, just a listing of our current policies, current principles, and then some other resources, landscape reports, a very interesting physician sentiment survey that we just did that's going to be driving a lot of our work on the regulatory space and likely the payment and coverage space ultimately. So, if these slides are shared, feel free to take a look at these and please let us know if you have any questions or want to discuss any of them anymore, but they should really kind of lay the groundwork for understanding where we're at and what we're advocating for right now on AI broadly. So that is it.
So thank you so much. And yes, we will try to get the slides separately from the video and post those. I see one question in the chat. Before I jump into that, I want to ask kind of a big picture question that I think touches on things you both spoke about, Shannon and Samantha. So a lot of the terminology, I think that people are having to wade through different types of terms. So there's FDA medical device regulation, there's clinical decision support, ONC has put out things about like I think it's MLDDS. Just I don't even remember what it stands for. But so if you just take an example of an assistive technology that is decision support for clinicians that is costly to implement, I would say that in my experience so far, there's almost no reimbursement path for that. So I'm curious, like, Samantha, are you seeing progress using the new code sets for how companies or health systems are trying to use this new set of tools to seek reimbursement for those types of technologies? And then Shannon, I'd want to get your input on what would I think you said a predictable coverage pathway even look like for that type of tool? Because I think it's unclear to me, like, where is the bar that we should even be trying to shoot for?
Yeah, I'll start out. I think, you've hit the nail on the head in terms of being somewhat challenged, especially with clinical decision support, because CPT codes define the physician work. So then if it's something that is not necessarily shifting the work, it's still the same amount of work that the physician has to do. It's hard to then get a practice expense component to cover something that is kind of just kind of on the periphery almost, and not maybe integral to the service that's being provided, even though it may be a very excellent tool and improve care. So the way the structure is set up right now, it doesn't necessarily account for that. And so that's why we're really encouraging people to apply for category 3 codes, even though they are not always reimbursed. They sometimes are. I think there's kind of a false idea out there that they're never paid for, but they are not automatically paid for in terms of the Medicare system. It would have to be based on each individual service with the contractor and discussions about that. But we have seen a large increase in the amount of people who are coming forward, especially with AI technologies for category 3 codes. And it's a great way to really track what those devices are doing, and to be able to kind of compile that evidence base and build the case for category 1 code in the future. So even though sometimes people are hesitant to apply for a category 3 code, we're really encouraging people to do that so that they can track that information and compile that evidence base.
Yeah, and as far as the second part of your question, when somebody knows what a consistent and predictable and good pathway to payment and coverages, I hope they let me know, because I'm not sure that anybody knows what that looks like right now, which is the challenge, right? You asked about what the bar is. I think that's why we don't have better pathways to coverage, is because we don't know yet, and everybody is very much trying to wade through that and figure it out. I, can tell you from some just kind of off the record things that I've heard from different folks in the payment space. You know, these costly solutions are going to be, I think, a challenge for folks. And I'm not saying that it's not going to ultimately be costly to implement some of these things, but when you do have these costly solutions, that's where that idea of value really comes in, right? You have to have the evidence that demonstrates the value at the end of the day, or there's not going to be a lot of interest from payers in paying a lot of money, paying more for things that do happen now without paying high dollar amounts for them unless they can do them better, unless they can do them faster, unless they can ultimately be like a cost savings tool at the end of the day. It's going to be a real uphill battle. But like I mentioned earlier, we don't have any harmonized evidentiary standards right now. And until we move closer to clarity, harmonization, like you mentioned, we don't even have any agreed upon terminology across the federal agencies. It's CDS, it's DSI, it's, a Lord knows what. If we can't even get those together, it's hard to, understand what consistency and predictability in these pathways for payment and coverage really looks like. There's those ideas like the TSET program out there. Maybe consider it a pilot right now, but maybe we learn a lot from pathways like that to where they can be expanded if the evidence, shows the benefit and the value at the end of the day. But again, if somebody figures this out, please let me know and we will be right there with you. But I wish I had a better answer, but it's a challenge.
Yeah, I have a question. Can I ask a question?
Yes, go ahead and please
So,
introduce yourself.
yes, my name is Joji Chori, and I'm from Hackensack Meridian Health, New Jersey. And you mentioned about the CPT being assigned to these AI devices. And one thing that we always monitor for our retinal screening, especially when it comes to the diabetic eye exam. But the device can be used only for screening. But if somebody is using it for monitoring diabetic retinopathy, it won't be reimbursed, right? So there is a kind of bias or unfairness in that type of reimbursement. Do you think like, this kind of gaps could be mitigated somehow so that people can actually use that and be more productive?
Yeah, I know that there has been, some discussion within the contractor medical directors and things like that about whether it can. Right now, it's really only for the screening element. I think that it does take a lot of discussion with
Right.
the people who are making those coverage determinations, and that's unfortunate because it takes a lot of time. You don't want to take time away from your patients, but I think continuing to talk about the different uses that some of these things can really help with, and there are CPT codes for things like monitoring, so it's possible that maybe some of these tools fit into different types of CPT codes depending on the way that they're being used. So,
Right.
I think that there can be discussion about that. Like, is there the option of using some of these technologies in different ways, using different kinds of physician services? So I think there's a lot of potential.
Okay. And you still use the traditional method, by taking into account the physician's work, the practice expense, and the liability piece in determining this CPT code for AI?
Yeah, I mean, right now, the AI that is represented by that is defined by CPT codes are still, within that traditional process of, the practice expense being the way to pay for the software. We have, in terms of Medicare, as one of the larger payers, they don't recognize software in terms of the practice expense. They consider it an indirect practice expense, but they have acknowledged that these types of services, especially when you're talking about the diabetic retinopathy,
Right.
are very important. And so the way that they've gotten around their own rules
Oh,
is
okay.
that they have crosswalked it to other services in the code set. And the AMA, our policy is that we think that it should be considered, that software should be considered a direct practice expense. And we have done a lot of advocacy in that space to push Medicare to acknowledge it as a direct practice expense. But
Right.
currently, the only way that they are paying for that is through crosswalking to other services.
Okay. And you still follow that traditional CMS's recommendation to create the CPT. You're not following the FDA, right? Because I see like, there are hundreds of AI-based devices being approved, but only 8 of them is reimbursed by CMS. And you have only those CPTs assigned to only those 8. Or do you changing
Yeah,
that
well,
policy to go with the FDA?
yeah, I mean, it really doesn't depend on either, because we're kind of in the middle of it in terms of the CPT editorial panel. So somebody would have to apply for a CPT code in order for a CPT code to be created for that service. So just because it's recognized through the FDA as software as a medical device and has been approved, doesn't mean that anybody has applied for a CPT code for it yet. But that's definitely a pathway that we encourage people to pursue.
Okay, so I know we're at time. Samantha and Sam and Shannon, thank you. I know Shannon had to drop off. Really appreciate it, and happy to share the slides as follow-up. And if folks have additional questions, I'm assuming they can reach out to you. Thank you.
All right. Thank you so much for inviting us. Appreciate it.
Thank you.